My topic for today's presentation is acute viral encephalitis revisited as it is today. I should first of all thank the organizers for having invited me to share this topic today. At the outset, let me say that I do not have any conflict of interest to disclose regarding this topic. The objectives of this presentation are to appreciate both common and unique features of CNS virus pathogenesis, to recognize the importance of early diagnostic testing and empiric therapy for suspected herpes simplex virus encephalitis, to know the modalities of treatment available for acute viral encephalitis. The important definitions that one should know are encephalopathy and encephalitis. By encephalopathy, we refer to a clinical syndrome of altered mental status manifesting as reduced consciousness or altered behavior. By encephalitis, you refer to an inflammation of the brain, which is strictly a pathological diagnosis. However, one can reach at a diagnosis of encephalitis by surrogate clinical and imaging markers that may provide evidence of inflammation. Let me share a few case examples. This is a 7-year-old female who came with history of 4-day history of nausea and vomiting, severe headache, loss of appetite, who's confused and unable to find the right word when she speaks. On examination, she was febrile, dysphasic, with no focal neurological signs. However, she had upgoing plantars and her C-reactive protein was elevated. This was a case of viral encephalitis. And now, an 8-year-old boy presented with acute right hemiplegia, aphasia, and altered sensorium with a sore throat. He was started on acyclovir with a diagnosis of encephalitis. The mother also, incidentally, had severe sore throat, and the father was admitted with pneumonia. The diagnosis was evident when the MRI came with a diffusion restriction of the splenium of the corpus callosum, which is described in H1N1 encephalitis. And both the parents also had the severe respiratory infection, which clinched the diagnosis and led to stopping of acyclovir, and oseltamivir made the child better. This is the third case. A 10-year-old was admitted comatose on examination. She was found to be weak on the right side, and the admitting diagnosis was a young stroke. However, the EEG showed generalized slowing with periodic lateralized epileptiform discharges, and the MRI brain showed hyperintensities of both temporal lobes, and this, along with the unrelenting coma, led to the diagnosis. Case 4 is a 6-year-old who was admitted drowsy. Following admission, he was noted to be having severe dysphagia. Examination revealed weakness of all bulbar muscles, bifacial paralysis, both trigeminal innervated muscles were weak, bilateral palatal paralysis, a weak voice, and the neck muscles were weak. There was weakness of all 4 limbs. He turned out to be having West Nile virus encephalitis. Now, this is the 5th case, a 4-year-old boy who remained in emergency for a day, saying he was seeing bulls. He was thought to be malingering. In a day's time, he became drowsy and progressed to coma. He was also having herpes simplex encephalitis. A 12-year-old boy was noticed in the petrol station near his school, aimless and over-talkative. The parents sought him well after school hours. They thought that he seemed to be drowsy, disoriented, and was brought to the casualty. This boy was also having herpes simplex encephalitis. A 7-year-old girl was brought with recurrent seizures over a day. She continued in altered sensorium. Later was noticed to have choreic movements of the limbs with intractable seizures. She turned out to have basal ganglia hyperintensities and was diagnosed as JAP-B encephalitis. So viral encephalitis, the clinical presentation is so varied. You have to have a high index of suspicion and thorough knowledge of the clinical features and the investigation modalities to make a diagnosis. The typical presentation of viral encephalitis could be acute flu-like prodrome, high fever, severe headache, nausea, vomiting, altered consciousness. The child could be lethargic, drowsy, confused, or in deep coma. Seizures may be a manifestation. Focal neurological signs may be present. More subtle presentations now recognized are low-grade fever, speech disturbances, dysphasia or aphasia, behavioral changes. The clinical presentation need not always be acute. There could be a subacute or chronic presentation, as can be seen in CMV encephalitis, which usually occurs in immunocompromised Bacillus osteovirus. Sometimes herpes zoster encephalitis, when it occurs in an immunocompromised, could have a subacute or chronic presentation. Any child with seizure and fever or seizure from which they do not recover must be investigated for possible CNS infection. This is the John Hopkins ABX guide as the diagnostic criteria for viral encephalitis. Diagnostic criteria for encephalitis and encephalopathy, presumed infectious or autoimmune etiology. The major criterion which is required is patient presenting to medical attention with altered mental status, defined as decreased or altered level of consciousness, lethargy, or personality change lasting more than 24 hours, with no alternative cause identified. Minor criteria: 2 are required for a possible encephalitis, more than or equal to 3 for probable or confirmed encephalitis. The minor criteria: documented fever more than 38 degrees centigrade, and generalized or partial seizures not fully attributable to a pre-existing seizure disorder, new onset focal neurological findings, CSF WBC count equal to or more than 5 per cubic millimeter, abnormality to the brain parenchyma or neuroimaging suggestive of encephalitis, that is either new from prior studies or appears acute at onset if this is the first MRI. Abnormality on electroencephalogram that is consistent with encephalitis and not attributable to another cause. Now, the causes of acute viral encephalitis can be either sporadic or geographically restricted. The sporadic causes include herpes, enterovirus, paramyxovirus, and others. Among the paramyxoviruses, one that is very famous today is Nipah virus. The herpes viruses include herpes simplex 1, 2, Bacillus osteovirus, cytomegalovirus, Epstein-Barr virus, and HHV6 and 7. There are a number of enteroviruses: Coxsackie echo enterovirus 7071, paracovirus, and poliovirus. And the paramyxoviruses include, in addition to Nipah, measles and mumps. And the other rarer causes are influenza, adenovirus, parvovirus, LCM virus, rubella, and rabies. The geographically restricted causes are the arboviruses in India. They are dengue, Japanese bee, and Kaisnu forest disease. Crimean hemorrhagic fever has also occurred in India, and there are sporadic reports of the other viral encephalitis too in India. The Banya viruses include La Crosse strain of California virus, and there are Rio viruses also. Now, the different viral encephalitis, they can be classified as enteroviruses, herpes virus, arbovirus, rabies, paramyxovirus, orthomyxovirus, and the coronavirus which has come recently. And these are all marked by the fact that the acute onset viral encephalitis are seen with arboviruses and herpes virus infection, whereas the manifestation could be acute to subacute with enteroviruses, rabies, paramyxovirus, orthomyxovirus, and the coronaviruses. It is of note that the vaccine is not available for any of these viral encephalitis except a few. As you know, we are now undergoing the coronavirus vaccination now. So also, we have vaccination for Jab B, and dengue vaccine is on the way. There are so many other features that help us to distinguish these viruses, which I am coming to in the next slides. Of note is the case fatality of virus encephalitis, which makes this subject so important. Japanese encephalitis in 2013, when there were 2,205 cases, the death reported was 590. So you know the high case fatality rate. In 2014, the case fatality rate was similar from Uttar Pradesh, Assam, West Bengal, and Bihar. Nipah virus encephalitis, which occurred in 2018 in Kerala, there were 21 deaths among the 29 identified cases. Ebola is another killer disease. Reported in West Africa in 2013-16, the death rate was 90%. Chandipura virus is called the killer virus. In 2003-4, Andhra Pradesh and Gujarat, the occurred in Andhra Pradesh and Gujarat, and the case fatality rate was up to 75%. So the case fatality makes viral encephalitis a very important issue. The arthropod vectors are again important because even though there is no real treatment for most of these viral encephalitis, one of the things that one can do is to control these vectors. And among them, mosquito control is very, very important because it is the mosquito which spreads Iype encephalitis, dengue, yellow fever, Rift Valley fever, St. Louis, Eastern equine encephalitis, Western equine encephalitis, Venezuelan equine encephalitis, and the Chandipura virus. The tick transmits Crimean Congo hemorrhagic fever, Kaisnu forest disease, and sandfly, again, in addition to mosquito, transmits the Chandipura, the killer virus. Animal reservoirs are also again important in many of these viral encephalitis. As you know, pigs are the reservoir for Iype encephalitis, monkey for Kaisnu forest disease and yellow fever, rodents are the reservoirs for some of these other encephalitis. Wild birds are important here because they act as reservoirs for Iype encephalitis. Kaisnu forest disease is also harbored in wild birds. The pteropid fruit bats have hit the headlines recently as they are the reservoir for Nipah virus, which caused so much death in Kerala in 2018. The SARS coronavirus is also harbored in these fruit bats. The history of Japanese encephalitis is most important in the epidemiology of viral encephalitis because it was recognized in Japan in 1800. In 1924, there was a Japan epidemic where there were 6,125 cases and 3,797 deaths. In 1935, the virus was isolated in the brain of a Japanese patient who died of encephalitis. And in 1938, the virus was isolated from the Culex mosquito in Japan. And there were outbreaks in Japan and Korea and China. And today, the disease is extremely prevalent in Southeast Asia. The prevalence is coming down with the Japanese encephalitis vaccine. The epidemiology of viral encephalitis in India, Iype, was first recognized in Tamil Nadu in 1955 in Culex vixnum. It was confined to Southeast Asia, India until 1973, until when there was an outbreak in West Bengal. From 1976, periodic outbreaks have occurred in Assam, Gorakhpur, Haryana, Goa, and Maharashtra, and now it's endemic in 14 states, including Tamil Nadu, Kerala, Assam, Bihar, Haryana, and Uttar Pradesh. The enteroviruses in UP in 2006, there was an outbreak. In Delhi in 2007, Lucknow 2008. All these outbreaks are important because of the fact that there is no real treatment. People are helpless when there's an outbreak of viral encephalitis. The H1N1 pandemic lasted for about 19 months from January 2009 to August 2010. As you know, the mortality was high, there was a lot of morbidity, and then came the vaccination for H1N1, and also the vaccination of JE occurred at around this time. And so after 2010, non-JE outbreaks have been seen. The Chandipura virus is very important in Indian scenario because it's a killer disease which has killed so many people. It was in 1965 that Chandipura virus was first caused the disease in Chandipura village, Nagpur district, Maharashtra, India. And later in 1967-69, there was an outbreak in Aurangabad, and then it was recognized in Africa also in 1975, 1993, 1994, 97, and it has come back to India in 2003, 2004, up to 2011 and caused a lot of mortality. Now, Nipah, the disease was recognized for the first time in Malaysia in 1998 only, and a total of 639 human cases have been reported, with 261 from Bangladesh, 85 from India, 11 from Singapore, 17 from Philippines, and in Kerala there was an outbreak in 2018, causing a lot of death. COVID-19 can also cause acute encephalitis as a clinical manifestation, though its respiratory illness is enough to cause death. It has increasingly been recognized as a neuropathogen with altered mental status ranging from mild confusion to deep coma, and most patients with encephalitis are critically ill. The typical CSF findings in CNS infections of viral encephalitis are: the opening pressure is high in viral encephalitis. The cells may show only a slight increase or may be there up to 1000 per cubic millimeter. They're usually lymphocytes, though in the early phase you can find neutrophils. The plasma to CSF glucose ratio will be normal, usually, and the protein will be high or normal. CNS viral infections or viral encephalitis are peculiar in that they could manifest as a pure encephalitis as in rabies, a pure meningitis as in mumps, lymphocytic choriomeningitis or Coxsackie, or as in the majority as a meningoencephalitis. Now, the management of an acute encephalitis syndrome. As the patient comes to you for the first time, you do not know what the organism is. You have to manage the child as an acute encephalitis syndrome. The evaluation and the treatment have to proceed simultaneously. It's a stepwise management. Step one is a rapid assessment and stabilization. At this point, you have no idea what organism is affecting the child. You establish and maintain the airway, see that the ventilation, oxygenation are appropriate, the circulation is re-established, identify signs of raised ICP and manage it, treat fever, seizures, hypoglycemia. Step two is a clinical evaluation, get the history and the examination, trying to find out the etiology. The investigation, the samples to be collected are CSF, blood, urine, MRI, CT if MRI is not available or possible. Avoid sedation because we push the child into deeper coma. Throat swab and nasopharyngeal swab and stool specimens are also to be collected. The empirical treatment should be started simultaneously. Ceftriaxone should be started in all cases until you're sure there is no bacterial meningitis. Acyclovir used in all suspected sporadic viral encephalitis, and you stop it only when you prove that you're not dealing with an encephalitis that needs acyclovir treatment. And artesunate is used especially when there is a suspicion of malaria or you're in a place where malaria is endemic. It is recommended that you start all three together, ceftriaxone, acyclovir, and artesunate, until each of these diagnoses have been disproved. Step 5 is a supportive care and treatment, which should go along with your empirical treatment, and then prevent and treat complications and rehabilitate the child. In patients with clinical clues suggest of rickettsial early kill infection, and during the appropriate season, doxycycline should be added to the empirical treatment. Consider stopping each of these empirical therapy with time. You stop the acyclovir if the PCR is negative on repeating the CSF PCR after 72 hours of disease onset, and if the sensorium and CSF are normal, or there is an alternate diagnosis. For example, you have got NMDA receptor antibody positive. You need not continue the acyclovir. If you're sure it's H1N1 encephalitis, there is no need to continue the acyclovir. You can continue with oseltamivir. The important points in the history of a child with an acute encephalitic syndrome are the prodromal symptoms, flu-like illness, pointing to H1N1, or diarrhea, enterovirus illness. You look for rash, vesicles, fast tissue, chickenpox. The residence of the child, whether it's rural, urban, endemic for cerebral malaria, or whether there is an epidemic of an acute encephalitis in the neighborhood, which would point to that organism. History of animal contact, insect bite, dog bite, which will help you to cleanse the etiological diagnosis. You also have to rule out all other diseases which could produce coma. Look for concurrent systemic illness like jaundice, pneumonia, diarrhea, dysentery. Family history of previous infant or child death. This child could be having an inborn error of metabolism producing an encephalopathy, and you may be thinking it's viral encephalitis. You look for premorbid developmental or neurological status of the child, which would indicate that this child could be having a neurodegenerative disease. Look for risk factors for immunodeficiency like HIV, or treatment for cancer, or immunosuppression, which could be the reason why this child is having a rare organism like CMV. Now, you look for drug or toxin exposure. It could be a toxic encephalopathy. Recent history of travel, as you know, SARS-CoV, it was first there in China, people who came from China had the disease. Trauma, it could be a subdural hemorrhage. History of seizure disorder, it could be non-convulsive status. Recent immunizations producing demyelinating disorder. History of recurrent episodes of encephalopathy as occurs in inborn errors in metabolism. The physical examination, very important. You look for extrapyramidal signs that will point to Japanese encephalitis, pallor for cerebral malaria or intracranial bleed. Icterus pointing to leptospirosis, hepatic encephalopathy or cerebral malaria. Skin rashes, petechiae, carotid swelling and otitis as in mumps. Labial herpes, rectal hemorrhages as in cerebral malaria. Myocarditis, which could point to EV71, and arthritis in parvovirus and lymphocytic meningitis, diarrhea, hypolimic shock, and Ebola. This is the picture of herpes labialis in the child with herpes simplex encephalitis, the vesicles of chickenpox. You should always keep the major treatable differential NMDA receptor antibody encephalitis in mind, because it is not just a disease to be excluded, it has got specific treatment, and you should always keep that in mind as you make a diagnosis of viral encephalitis. The CSF examination includes the examination of the opening pressure, send samples for cell count differential, protein glucose, rad stain culture, viral PCRs, and other tests as appropriate. For example, if you suspect tuberculosis, meningitis, do the test, and viral specific IgM antibodies when you suspect JAPI encephalitis. And these are the diagnostic tests that should be tailored, made for each child. For HSV, you do the DNA in CSF by PCR, consider repeating after 2 to 7 days of disease if negative in the beginning and there's a high clinical index of suspicion. For JE virus, you do the specific IgM in the CSF, enterovirus PCR in CSF, and isolation from the stool is also done. Mumps, detection of mumps virus RNA in CSF by PCR, varicella zoster DNA by PCR and CSF, Nipah, detection of Nipah virus specific IgM antibodies in serum and CSF, and Chandipura, detection of IgM antibodies in CSF and nested RT-PCR. The diagnostic tests are based again on suspicion for Iype virus. You do the serum Iype virus capsid antigen IgG IgM and Iype virus nuclear antigen IgG. HSV6, you do the CSF PCR. Influenza PCR of respiratory secretions, dengue CSF PCR or CSF specific IgM. Measles CSF specific IgG, CMV CSF PCR. When clinical suspicion warrants, anti-NMDA receptor and anti-VGKC antibodies should be sent in CSF and blood samples and appropriate treatment given. The MRI is very, very useful to make a diagnosis. In herpes simplex encephalitis, these temporal lobe hyperintensities help in clinching the diagnosis. COVID-19 encephalitis, there are a variety of MRI pictures that have been reported. These white matter hyperintensities, this is the thalamic hyperintensity report in another case. The double donut sign in dengue and encephalitis helps in making a diagnosis. This is the double donut sign. This is the diffusion weighted image showing the double donut sign. The ADC showing the hypointensity in the hyperintense area seen on diffusion weighted image. H1N1 encephalopathy, this is one of our cases which showed a splenial hyperintensity. And H1N1 encephalitis is peculiar in that it can produce lobar hyperintensities, it can produce basal ganglia hyperintensities or a splenial hyperintensity. But when you find the splenial hyperintensity in a patient with encephalitis, it is you can be suspicious that this patient is having H1N1 encephalitis. In JAPI encephalitis, the MRI findings are abnormal signal intensity in the thalami, substantia nigra, and basal ganglia. In enterovirus 71, you have brainstem hyperintensities with dentate nuclei of the cerebellum also getting affected. Chandipura virus, the MRI will be normal. Nipah can show deep white matter hyperintensities. Varicella, you get multifocal abnormalities in the cortex with cerebellitis. West Nile, you find abnormalities, the deep gray matter and brainstem, and white matter lesions mimic demyelination with also meningeal involvement. The blood investigations. To look for IgM for any virus, you have to take the blood at least 5 days after the onset of illness. As you know, IgM production will be delayed for at least 5 days. And the second sample should be taken at least 10 to 14 days after the first. A clotted sample, which can be stored at 4 to 8 degrees for 24 hours. Beyond that, you have to freeze at minus 20 degrees centigrade. The CSF, when you take, can be stored for less than 24 hours at 4 degrees. There's a greater delay, you have to freeze at minus 80 degrees centigrade. Swabs, when you take swabs for virus, you have to take it in a viral transport medium. And urine 10 to 20 ml, again, it should be stored at minus 20 degrees centigrade if you need to isolate the virus. The stool for enterovirus culture also should be taken, stored at minus 20 degrees. Brain specimens, when taken, should be collected unfixed. The viral antigen detection is by immunofluorescent antibody staining. The EEG is an important tool in the diagnosis of viral encephalitis. All cases will show a slow background rhythm with periodic lateralized epileptiform discharges in some cases, and there may be pseudo-periodic forms. This is a case of viral encephalitis showing only slowing, uniform slowing in all the leads. There are no periodic lateralized epileptiform discharges. This is another EEG showing. This is the left side. All the 8 leads on the top are the left side, and the next the leads on the bottom or the right. You find these lateralized epileptiform discharges only on the left side. These are the periodic lateralized epileptiform discharges. Periodic lateralized epileptiform discharges, which are regional, not all over the left side. It is seen only in the temporo-occipital region. The frontal region is spared. This is regional periodic lateralized epileptiform discharges in a patient with herpes simplex encephalitis. Now, this is another patient with herpes simplex encephalitis who had periodic lateralized epileptiform discharges, which with time has shown increase in the frequency. This is a electrographic seizure that is occurring in this child with herpes simplex encephalitis. The plates have gone progressed to form epileptiform discharges, as formed electrical seizure discharges. The management of viral encephalitis, acyclovir should be started as soon as you suspect viral encephalitis and until you prove that this is not herpes simplex encephalitis. From 3 months to 12 years, the dose recommended is 500 milligram per meter square given 8 hourly, and beyond 12 years, it's 10 milligram per kilogram given 8 hourly. The child weighs 80 kilos, you should give 800 milligram 8 hourly. And in confirmed cases, the duration of treatment is 14 to 21 days. 21 days is the recommended period, and depending on various factors, you may change to 14 to 21 days. Minimum of 21 days for those aged 3 months to 12 years. And if the PCR in your CSF was positive in the beginning, PCR should be repeated at 21 days and you should demonstrate that PCR is negative. If PCR is positive in CSF for herpes simplex virus at 21 days, you have to continue acyclovir and repeat every 1 week until PCR in CSF for herpes simplex virus is negative. The minimum period is 21 days. Repeat CSF every week until PCR for herpes simplex virus is negative. Stop acyclovir if an alternative diagnosis is confirmed, for example, H1N1 encephalitis or autoimmune encephalitis. You can stop the acyclovir, or if the HSV PCR and CSF is negative on 2 occasions, at least 24 to 48 hours apart. Both are negative, at least 24 to 48 hours apart. And the MR imaging does not suggest herpes simplex encephalitis. You can stop the acyclovir. Now, the treatment in the neonate, the dose of acyclovir is 20 milligram per kilogram per dose given 8 hourly, that's 60 milligram per kilogram per day. And the preterm, the dosing interval depends upon the creatinine clearance. And the side effects of acyclovir are neutropenia, liver dysfunction, hallucinations, tremor, myoclonus, disorientation, which you should keep in mind. You should monitor the renal function as you treat. And continue acyclovir until CSF PCR is negative, IVIG has no value, steroids have no value in the treatment of herpes simplex encephalitis. Higher dose of acyclovir are associated with neutropenia and should not be experimented. The recommended dose should be given. Acyclovir is highly selective in acting against these viruses, HSV1, 2, varicella zoster, Epstein-Barr virus, and cytomegalovirus. Vidarabine is an alternative agent used in the past which is inferior to acyclovir. Foscarnet can be used 120 mg per kilogram per day. It is a drug of choice in HIV patients with herpes simplex encephalitis and in acyclovir resistance. Valacyclovir is available in India. It's an alternative that can be taken orally. It is not the recommended alternative. It is an alternative that can be taken orally. The prognosis in herpes simplex encephalitis mortality is more than 70% if untreated and just 20% with treatment. The poor prognostic factors: age above 60, the GC less than 7, and delay in starting a cycle, especially if it's more than 2 days. And two-thirds patients have neuropsychiatric sequelae even with treatment. The management of HSV 1 and 2, acyclovir has been described. Varicella zoster virus, acyclovir again is the treatment. If there is evidence of vasculopathy, corticosteroids have to be added. In cerebralitis, no antiviral is recommended. Enterovirus, there is no specific treatment. IVIG has been tried anecdotally in many. In Epstein-Barr virus, there are anecdotal reports of acyclovir and ganciclovir, HSV6, ganciclovir or foscarnet. Influenza, oseltamivir, amantadine is an alternative. Dengue, Zika, and chikungunya, there is no treatment. Measles, there is no treatment. There is no antiviral treatment. CMV, ganciclovir, CMV encephalitis, ganciclovir for 4 weeks. Measles, ribavirin can be considered. Nipah, ribavirin can be considered. West Nile, ribavirin is not recommended. Epstein-Barr virus, interferon is not recommended. St. Louis encephalitis, interferon is recommended. HIV, you give heart treatment. For JC virus, reversal of immunosuppression or heart in HIV infected patients. Now, encephalitic rabies, there are prodromal. This is very relevant in India, and therefore I have added 2 slides. There are prodromal symptoms followed by paresthesia, pain, pruritus at the site of bite, episodes of generalized arousal or hyperexcitability, separated by lucid periods. Autonomic dysfunction clinches the diagnosis with the history of dog bite, hypersalivation, loose flesh, cardiac arrhythmias, and priapism in males. Hydrophobia again clinches the diagnosis. Paralytic rabies, there will be paresthesia, pain, and pruritus at the site of bite. Early flaccid muscle weakness begins at the bitten extremity, progresses to produce quadriparesis, bilateral facial weakness. Sensory examination will be normal, thus distinguishing it from a spinal cord affection. Sphincter involvement will be there, distinguishing it from GBS. Usually there is a fatal outcome. The recommended prophylaxis in exposed individuals not previously vaccinated against rabies. Wound site immediately should be cleaned. Tetanus prophylaxis and antibiotics should be given. Human rabies immunoglobulin should be infiltrated in the wound at 20 units per kilogram body weight. As much as of it should be infiltrated around the wound, and the remaining should be given IM at a distant site. Rabies vaccine should be given deltoid area on days 0, 3, 7, 14, and 28. The mosquito control measures are important in the arboviral encephalitis that are transmitted by mosquitoes. You reduce the number of breeding sites on your property, kill mosquito larvae where the insects breed, and remove algae from ponds. Use a mosquito repellent in your outdoor living space and exclude mosquitoes from your home using net on your windows, and increase the number of mosquito predators in your yard using fish, etc. So vaccination, most of the encephalitis have no vaccination. JE vaccine is the most famous among the vaccines that are available. It appears to be 91% effective. In fact, JE has reduced tremendously after vaccination. And however, there is no JE specific therapy other than supportive care if a patient develops the disease. A live attenuated SA1414-2 JE vaccine has been licensed and used in Asian countries, including India. And now there is the Vero cell derived inactivated JE vaccine, and Japan is also produced a chimeric vaccine where JE and yellow fever vaccine are combined together. Dengue vaccine, Takeda's dengue vaccine is passed the second of a 3-part late-stage test, and it will be used widely in the near future. It's an investigation live attenuated tetravalent dengue vaccine. Personal protective equipment cannot be reiterated enough. As everybody knows, the prophylaxis of highly contagious viral encephalitis like Nipah and SARS-CoV-2 involves use of personal protective equipment. Pre-exposure rabies prophylaxis. 3 doses of rabies vaccine at days 0, 7, 21 or 28 may be given as pre-exposure rabies prophylaxis people who are highly prone to get dog bites. And these people who are prone to get dog bites, they check the rabies antibody titer periodically, and it should be more than zero point 0.5 IU per ml. And these people who have been already vaccinated after rabies exposure need to take 2 doses of IM rabies vaccine on days 0 and 3. They do not need immunoglobulin. Intradermal use of rabies vaccine is the gold standard is IM administration. However, intradermal regimen is an acceptable alternative because you use less of the vaccine can be used for more people. 1/10 of the dose need be given intradermally. There's a comparable degree of protection. It's economical and widely accepted. So, to conclude my talk, all possible efforts should be made to establish the specific diagnosis using epidemiological information, clinical presentation, and ancillary tests. It's important to know the best approach to collecting samples and to choose the best identification technique for each virus. Treatment for specific viral etiologies may be initiated as soon as possible. When there's a high level of suspicion, empirical antiviral treatment is reasonable until etiological confirmation is possible. Further research is also required to develop new therapies for unmet medical needs like arboviral and enterovirus infections. Thank you.